Yep. Okay, here we go.
Hi, everybody. Thank you so much for joining. We'll just get started in 1 minute. Hi, everybody. Thanks for joining. We'll just get started in 1 minute. Thanks for coming. Okay, I think we'll get started. Thank you so much, everyone, for coming. My name is Michelle. I use she, her pronouns. I'm the project manager of the research team here at Pregnancy Justice, and I'm joined by my colleagues Vikayo and Iman here as well today. Welcome to our second webinar of our Policing Pregnancy series. Today, I'll kick us off with a brief presentation of our exciting new data findings, and then we'll have a really great panel discussion with some state partners and then close with a Q&A. Just some housekeeping. If you have any questions, please feel free to drop it in the Q&A box at the bottom of your screen. Also, if you are a reporter, this webinar is background and not to be used for quotes. If you would like a quote attributable to Pregnancy Justice, you can reach out to us at media@pregnancyjusticeus.org. Iman will drop that information in the chat. Thank you all so much for coming today. So lovely to see so many new and familiar faces on this call. Okay, so for folks who are new, Pregnancy Justice is a national legal advocacy organization that defends the civil and human rights of pregnant people. We do this through robust legal defense, strategic policy advocacy, and collaborative research like we're presenting today. At Pregnancy Justice, we envision a world where all people, regardless of pregnancy status or outcome, have the freedom to make decisions about their bodies and experience a life of dignity, equity, and respect. The focus of today is pregnancy criminalization. And what we mean by that is when the state wields a criminal law to render acts associated with a pregnancy, pregnancy loss, birth, or associated healthcare the subject of criminal prosecution. This includes punishing actions during pregnancy, such as drug use, that are not often otherwise punishable but become that way because of pregnancy. Pregnancy criminalization goes hand in hand with fetal personhood, which is an extreme radical legal concept that fertilized eggs, embryos, and fetuses have the same legal rights and protections as everyone in this room and more than the person carrying the pregnancy. Fetal personhood is central to criminalizing conduct and health conditions during pregnancy. And I know that this concept was discussed in depth during part 1 of this webinar series. So if you missed it, I really encourage you to look out for our recording on our YouTube. Pregnancy criminalization is not a new phenomenon. Alongside other researchers and journalists, Pregnancy Justice has been one of the leaders in tracking pregnancy criminalization and its impacts across the United States for decades. We have data going back to 1973 when Roe was made into law. That includes nearly 1,800 cases between 1973 and June 2022, the date of the Dobbs ruling, which overturned Roe. Now in deep partnership with academic institutions across the country, including our co-principal investigators, Professors Wendy Bach and Madeline Wasilchek, we are building on this expertise and tracking pregnancy criminalization in post-Dobbs America. Today, we're really looking forward to sharing new findings on 412 cases we've identified in the first 2 years post-Dobbs. So first, we just wanted to name some caveats. We are researchers after all. First, it's important to note that data come from court files, charging documents, and police investigation reports. In other words, this is what police and prosecutors alleged happened in a case. This can teach us a great deal about pregnancy criminalization, and also we know that allegations are not necessarily the same as facts. These files also would not necessarily tell us what the defense would argue in these cases. It also means that information like racial demographic data from these files might not always be completely accurate. Second, this data is preliminary, in part because researching pregnancy criminalization is incredibly challenging and time and resource intensive. There is no centralized database to view court records across the United States, and every state has their own system, sometimes even county by county. And as I will describe a little bit later on in this presentation, pregnant people are also often charged under general crimes like child neglect, endangerment, or homicide. And so as a result, these cases are not in plain sight. We have to rely on and develop innovative methods to identify them. So we use media tracking, legal intake at Pregnancy Justice, outreach, partnerships in key states, some of whom I see on this call today, thanks for joining, and various records requests to court offices. And so we know it shouldn't be this hard. They're making it very hard for us to truly understand what is happening in our communities. And finally, I'll just mention that our study is protected by the Institutional Review Board, and confidentiality is of utmost importance to us. Okay, so what does this new data include? As I said, we're sharing preliminary findings from the first 2 years post-Dobbs. Our data are focused on pregnant people who are prosecuted and the charges and allegations made against them. This means that this data does not include healthcare providers or helpers or support networks. But many on this call are doing really incredible work amidst the really harmful and egregious threats to healthcare providers and helpers in a post-Dobbs landscape. So we're really lucky to be in this work together. Our research is just focused on pregnant people who are prosecuted. And finally, this research is deeply collaborative. It is a result of a multi-institution academic collaboration with scholars at the University of Tennessee, Knoxville, University of South Carolina, University of Texas, Austin, University of Alabama, and University of Tulsa, and many other partners, some of whom are here today. Thanks so much for this collaborative work. Okay, so to dive in, as I mentioned, in the first 2 years after Dobbs, prosecutors initiated at least 412 cases charging pregnant people with crimes related to pregnancy, pregnancy loss, or birth. Pregnancy-related prosecutions were initiated in 16 states, with Alabama, Oklahoma, and South Carolina representing the largest number of cases currently. And we're so excited to have state partners on the call today from each of those states to speak more about this issue and their work on the ground. 5 of the 6 states with the highest number of prosecutions have explicitly granted legal rights to fertilize eggs, embryos, and fetuses in their civil and criminal laws. Therefore, fetal personhood laws really paved the way for pregnancy criminalization. Now, to address what we know so far about who this is happening to, when it comes to racial demographics, it's really important to take a step back and contextualize the criminalization of pregnancy in its deep racist patriarchal roots that target poor Black, Native American, and Latinx women. As I mentioned, pregnancy criminalization is not a new phenomenon, especially when we recall the legacy of the war on drugs of the 1980s, when prosecutors relied on now discredited racist narratives about in utero exposure to crack cocaine to charge predominantly poor Black women with child abuse. In the mid-2000s and into today, drug patterns have shifted, and the target of pregnancy prosecutions have reflected those shifts to include opioids and methamphetamines and the predominantly white communities who use these drugs. What we see similarly in our data so far is that most pregnant people who were charged are poor white women. What this signals to us is that the tactics used to criminalize Black women are now being extended, though in different ways, to poor white women, specifically poor white women who use drugs, especially in rural areas. This topic could be truly its own separate webinar. So for now, Iman will drop a really great article that we recommend by an incredible expert in the field and former board member, Kiara Bridges, who has analyzed this phenomenon and has really interesting theories on this. One common denominator, though, that we know is socioeconomic status. In line with previous trends, the majority of cases involve pregnant people who have low incomes, many of whom rely on programs like Medicaid for healthcare and services. So what are pregnant people being charged with? As a reminder, one case can have more than one charge, and overwhelmingly we found that prosecutors used existing child endangerment, neglect, or abuse statutes beyond their original intent to criminalize pregnancy. In our study, that was the case in 398 charges. Therefore, prosecutors actually don't need any new laws to prosecute pregnant people because granting legal rights to fetuses paves the way for prosecutors to use existing laws to prosecute pregnant people. And then if we look at pregnancy outcomes, the majority of cases involve live births. However, it's really significant to us that prosecutors criminalized 31 pregnant people who experienced a pregnancy loss, including miscarriage or stillbirth. Pregnancy loss is a widely shared personal and medical experience, but pregnancy loss today is being treated as a suspicious event to be surveilled by the state. No one should lose their autonomy or their basic rights because they are pregnant or because of a pregnancy outcome. And then when we look into the allegations that are being brought against pregnant people, we see clearly the way the state controls and punishes behaviors, conduct, and healthcare decisions during pregnancy. To level set again, each case can have more than one charge, and each case can also have more than one allegation. And we looked at the allegations for in all of these 412 cases and have highlighted 3 of them here. As has historically been the case, the majority of prosecutions are fueled by a punitive approach to substance use, 399 allegations of substance use during pregnancy in our data set. So what we're seeing is instead of meeting drug use or substance use disorder with healthcare and access to resources and treatment, it's being met with stigma, punishment, and control, not to mention in the midst of a national opioid epidemic. Also striking is in 29 cases, prosecutors argued that pregnant people's failure to obtain prenatal care was evidence of a crime. So, for example, in a case where a pregnant person is charged with, say, child neglect endangerment for alleged substance use during pregnancy, the allegations may also mention that she did not obtain prenatal care. So what we see is pregnant people's lack of healthcare access is being used against them in these cases. It's a maternal health crisis that is one of the worst in the world, that is disproportionately impacting Black women and creating maternal health care deserts across the country. And then when it comes to abortion, even if a pregnant person is not being prosecuted for an abortion-specific charge, allegations related to abortion can appear in these cases. In our study, we saw this happen in 9 cases. To highlight this a bit more, as you can see on the screen, pregnant people were alleged to have, quote, visited a clinic for abortion or researched through Planned Parenthood, how does the abortion pill work, or ordered a pill on the website, and then that pill was on the evidence list. They were charged with things like homicide or child neglect or endangerment. Although it's not clear exactly how the state intends to use this information, these cases clearly show that pregnant people's contemplation of abortion can be weaponized against them in these cases. And then supporters of pregnancy-related prosecutions often claim that these prosecutions protect the fetus from harm perpetuated by the pregnant person. However, we found prosecutors overwhelmingly charge pregnant people under statutes that allow them to obtain convictions without proving that the pregnant person actually harmed the fetus or the infant. So in 378 charges, proof of harm to the fetus was not required of the prosecution. A mere positive toxicology test or admission of using substances alone was enough to meet the legal requirement of neglect with these statutes. And then how do these prosecutions happen? Our data indicate that pregnancy criminalization engages multiple systems to support these prosecutions, notably the healthcare and family policing systems, also known as the child welfare system. So in 264 cases, information was obtained or disclosed in a medical setting. In 217 cases, the family policing system was involved in the case. These data, which are likely an undercount, suggest that both systems work closely with the criminal legal system to surveil and punish pregnant people. And at Pregnancy Justice, we know that through our work, what this sometimes looks like is pregnant people being drug tested in a hospital without their consent, and the results of those tests are shared with family policing agencies who share that information with law enforcement. And we can all agree hospitals should be sites of compassionate and confidential care, and patients should be able to trust their providers without fearing criminalization. As we wrap up, after all of those graphs and data, I like to just reiterate that these 412 cases are pregnant or postpartum people, many of whom are mothers or who have experienced a pregnancy loss. It is really hard to overstate the harms of pregnancy-related prosecutions on a pregnant person, their family, and their communities. Each of these 412 cases represents a pregnant person who experienced an invasive investigation or a traumatizing arrest. These individuals may have sought health care for a medical emergency, prenatal care, pregnancy loss, only to have law enforcement called on them. Many of these individuals experience incarceration and family separation from their children. Even during a case, a person spends time going to court dates, may lose their job because of the charges, pays court fees, and may face stigma in the media or in their community. These cases are deeply traumatic experiences and have rippling and intergenerational impacts for years to come. And finally, as we'll hear from our panelists today, pregnancy-related prosecutions are a public health issue. Research has repeatedly demonstrated that criminalization produces worse maternal and infant health outcomes, and the fear of criminalization turns pregnant people away from seeking care, sometimes when they need it most. So I hope you will stay connected to us. We will continue this research in earnest for years to come. We will continue to identify and analyze post-op cases. We plan to write more in-depth analysis in academic publications and presentations to the field. And we also plan to uplift the direct experiences and voices of people who have faced pregnancy criminalization through a qualitative component of our study led by our postdoc, Dr. Kendra Hutchins. Thank you all so much for your time today. All the data is available on our website, which Iman has dropped in the chat. Now for the main event, I will pass to Fikayo, our amazing senior research associate, to moderate our panel discussion. Thank you all.
Hello, thank you so much, Michelle. I think we are really excited to introduce our three panelists and state level partners from Alabama, Oklahoma, and South Carolina. Before I introduce them, I just want to reiterate again that if you're a reporter, this discussion is not for quotes, and if you would like an attributable quote, you can again reach out to Pregnancy Justice. So I'm going to begin with Dr.
Bless you.
Arisha A. Bowers, who is the Deputy Director of Yellowhammer Fund. She holds a Bachelor of Fine Arts and multiple master's degrees, including a Master's of Education and a PhD in Interdisciplinary Studies, a Graduate Certificate in Women and Gender Studies, a Certificate in Complementary Alternative Medicine, and a certificate and licensure in chaplaincy. So Arisha has over 25 years of experience in social services, nonprofit leadership, management, program design, and civic leadership. Her life's work is to bring together women's studies, education, interdisciplinarity, and creativity, as well as spirituality, healing, wellness, and movement. So she really uses her scholarship and vocation to do healing work in faith communities and communities of color, focusing on reproductive health and women's issues. She's also an ordained minister through the Universal Life Church and really combines a spiritual focus with the therapeutic disciplines of mindfulness dancing to offer healing practices across the US and abroad. To introduce Caitlin Beasley, who is a public relations professional turned policy wonk, combining research expertise and frontline experience supporting health and human service providers to advance the health of Oklahoma women. As a policy engagement manager and matriarch and chair of the Oklahoma Coalition Against Human Trafficking Data and Policy Committee, she leverages rigorous research and ethical storytelling to drive effective, actionable empathy. And finally, to introduce Dr. Courtney King, who is an assistant professor in the Department of Psychiatry and Behavioral Sciences, as well as the Associate Director of Research for the Women's Reproductive Behavioral Health Division and Director of the Rebirth Program at MUSC. Her work focuses on integrating allied professionals onto multidisciplinary care teams to improve maternal mental health and birth outcomes. She believes deeply in the healing power of mutual understanding and aims to create more spaces in which individuals can use their stories of resilience to uplift and walk alongside others on a similar path. Thank you all for being here today. To begin, I really just wanted to ask each of you to just describe a little bit, to talk a little bit about your organization's mission, and just to share what you want people to know about your state. Dr. King, can I start with you?
Yeah, absolutely. So I work for the Women's Reproductive Behavioral Health Division, and our mission is to improve the emotional health and the well-being of pregnant and postpartum women through clinical care, education, teaching, and clinical research. So our department includes an outpatient clinic with a whole range of different clinicians, perinatal psychiatrists, residents and fellows, psychologists, counselors, social workers, peer support, and peer recovery doulas, as well as a really large research team that's supporting service-based programs like a perinatal psychiatry access program that's statewide, all the way to large clinical trials that are looking at technology-facilitated interventions that improve screening and referral and treatment to care for perinatal mental health and substance use disorders. And what I want to mention about the state of South Carolina is just understanding what the landscape there looks like. So about a third of our population lives in rural areas. 46 of our, or sorry, excuse me, of our 46 counties, HRSA has designated 43, so that's over 90%, as completely or partially medically underserved. Roughly 10 of our counties are maternity care deserts. We're consistently ranked really low in access to mental health care. I think our most recent rating was 49 out of 50 states. And there's a shortage of specialized services for pregnant people. So and when it comes to perinatal substance use disorder, there's only 3 mommy and baby residential treatment centers for perinatal substance use disorder. And our state faces really high rates of poverty. 60% of the total births are covered by Medicaid. And that results in a lot of unaddressed social determinants of health, which compound with South Carolina's long history of racism and discrimination to create a lot of health disparities. So as a result, South Carolina, just like the rest of the country, but especially in our state, is facing a really devastating maternal health emergency. So much so that our state ranks 8th highest nationally for maternal deaths. And we earned an F grade from the March of Dimes for our prenatal birth rate, ranking us 44th nationally for the 3rd consecutive year. So thinking about all of that, South Carolina is really the state where systemic healthcare inequities intersect with geographic and socioeconomic barriers and structural racism to create this very challenging landscape for maternal care. The last thing I want to quickly highlight is that even though we're struggling in terms of the maternal care landscape, the good news is that in response to this, there's a lot of innovative programs and initiatives that are popping up within the maternal care space to support pregnant and postpartum women and their families within state agencies, academic medicine, and really at the community level. We're seeing a lot of.
That's fantastic. Dr. Bowers, can I throw it to you to share a little bit about Yellowhammer Fund's mission?
Yes. Hello, everybody. The Yellowhammer Fund is a 501c3 abortion access fund, advocacy, and reproductive justice organization. We serve Alabama, Mississippi, and the Deep South. We envision a society in which reproductive decisions are made free from coercion, shame, or state interference. We want a society in which individuals and communities have the autonomy in making healthy choices regarding their own bodies and their futures. And we simply commit ourselves to educating the community, empowering community members, affecting change within policy and advocacy, and creating and developing systems of mutual aid and support for our friends, families, and neighbors. Yellowhammer Fund is dedicated to making sure that we begin all of our work at the center where those who are most impacted reside, and meeting them where they are, but not leaving them behind. Similar to what Dr. King shared already about South Carolina, you can find many of the same kind of health disparities in Alabama. And I won't repeat those things, but I will say that there are new innovations that are underway in Alabama. We just recently launched the Alabama Birth Equity Initiative, and it is for and by community members who are interested in ensuring that people who can give birth get all the resources that they need, as well as centering the voices of those most impacted. Thank you.
Thank you. And now, Caitlin, I'll turn it to you to talk a little bit about Matriarch.
Yeah, sure thing. So I'm Caitlin. I've been policy engagement manager at Metriarch for about 3 years now. And Metriarch is a nonprofit, nonpartisan research organization. It's been improving the health of Oklahoma women for about 7 years now. And the way we do that, we monitor and research policy with potential impact on the women in our state and develop tools that help others do the same. And I really feel like could repeat what Dr. King and Dr. Bauer said about Oklahoma specifically. We rank poorly in most women's health outcomes in general, including the rate at which we charge women with crimes related to their pregnancies. But again, like mirroring the same narrative that my colleagues are articulating, that despite this challenging political and legal environment, there are incredible partnerships that span private, public, philanthropic, and then institutional settings. So one thing I just want to highlight, because it's something we've been working on with pregnancy justice, is the reproductive justice practicum that we helped establish at the University of Tulsa School of Law. I think for the last 4 or 5 semesters we were talking about it. We couldn't really remember because time flies when you're working with cool people. But we've been working alongside law professors, students, and organizations like Pregnancy Justice to delve into the most pressing legal issues facing the women in our state. And that includes, unfortunately, tracking and analyzing pregnancy criminalization cases.
Thank you. So as we discussed in our latest findings, and we've reiterated here, like pregnancy criminalization, they've been found across various states, but a real significant portion of those cases have originated in your respective states. So from your perspective, how do you see pregnancy criminalization showing up in your work? Dr. King, can I start with you again?
Absolutely. Yeah. So similar to the data that was presented, what we consistently see is that punitive laws in response to perinatal substance use disorder are one of the biggest barriers to both prenatal care and treatment access. So when a patient is feeling, when patients are fearing legal and social consequences, they are less likely to disclose their substance use, or they avoid prenatal care and treatment services entirely. And this results, obviously, in delayed or absent prenatal care, which we know is associated with poor obstetric outcomes like stillbirth and neonatal absence syndrome and even infant death, as well as lower rates of recovery into the postpartum period or longer term, which is associated with things like increases in child neglect and foster care entry and decreased rates of parental unification related to those substance use disorders. And so having barriers like that is tough, because we know that pregnancy is this like very critical intervention opportunity. During this period, women have health insurance that they might not normally have access to. They can potentially be in regular contact with healthcare, and they're really motivated, just like the general population, towards positive behavioral changes to invest in their baby's future and their future. So early identification and evidence-based treatment during pregnancy can really improve maternal and infant outcomes, and potentially impact intergenerational patterns. They can break cycles if we can intervene. So it's really important to meet that motivation with compassion, but these punitive approaches intensify stigma and shame, which we know are huge barriers to accessing mental health care and substance use disorder treatment. And they're really undermining that very window of opportunity that pregnancy provides for intervention to support both mom and baby's health. So we're losing our opportunity to really turn healthcare around.
Thank you. Caitlin, would you mind speaking a little bit about what you see in your work in Oklahoma?
Absolutely. So we're not direct service providers, we're a research organization, but we started looking into this 5 years ago because our partners that are providing direct services were flagging it as an issue. So we just launched a report on it called Paths to Recovery. It's mixed methods. We interviewed people with lived experience and those who worked with them to really understand what was going on with pregnant people who were trying to navigate a substance use disorder in our state, and kind of mapped out, really what, not only what was going on, but like, what are our policy levers, whether we're talking about policies like in individual like care settings or at the state level statute that is really causing this problem. And I'll talk a little bit about some of those findings, but definitely if you want the deep dive, the report has you covered. But it's really a legal battleground in Oklahoma right now. We're starting to see public health surveillance and medical and social service provision being weaponized by prosecutors to charge women with crimes, which you were talking about earlier when you were presenting pregnancy justice's results. And they're doing so using largely like extant statute and administrative rules that were initially put in place for other purposes. So I've had an interesting conglomeration of changes that I think have led to this spike in Oklahoma, where we had medical marijuana that was legalized via ballot initiative around the same time that our mandatory reporting laws were tweaked slightly. And that's during usually labor and delivery. If there's a drug test at the umbilical cord or meconium, our medical providers are required to report that to our Department of Human Services. And instead of just reporting dangerous and illegal substance, or instead of reporting dangerous and controlled substances, they were then required to report dangerous and illegal ones. So marijuana started popping up a lot more, and these required reports started filing in and then being referred to prosecutors that have jurisdiction in those areas. And then our Oklahoma Court of Criminal Appeals started ruling on some of this stuff. They did determine definitively that using marijuana use or using drugs during pregnancy does fall under our state's definition of child neglect. Then they ruled against that in the case of licensed medical marijuana use, but went ahead and flagged to our state legislature that if they would like to change that, they would need to pass a law to do so. And what did we see last legislative session but a bill that would have done that? So I feel like we're really on the precipice of going down this path that historically we've seen does not work, as Dr. King hinted at earlier, where we're going to get more punitive rather than providing more supportive services.
Thank you. Dr. Bowers, would you like to share a little bit about what you're seeing in Alabama?
Yes. Pregnancy criminalization in Alabama it's a legal issue, but I believe that it is a deeply spiritual, ethical, and community concern, and it intersects with the work that we do in reproductive health rights and justice. For me, prosecution for substance use during pregnancy, like Alabama leads the nation in criminalizing pregnant people for even alleged substance use, like even when no harm occurs to a child. Hospital staff and folks who are working with families often initiate law enforcement involvement. And this triggers arrest and prosecution. We see this disproportionately affects poor Black and white women in the rural parts of the community, poor women in the urban parts of the community, and honestly, similar to what has already been shared, many folks who don't have access to addiction treatment, and they forego prenatal care in a lot of cases because of fear of criminalization and being reported. So to protect their unborn child, but also to protect any other children that may be in the home or any other persons that they may be caring for. We also see this show up for folks fearing reaching out for multiple other different types of support as well. So if there's a person who may be reaching out for assistance with domestic violence, they may not reach out just because, again, those things can be used against them by their abuser, or it can be used against them, by folks who are working in these different facilities. As previously mentioned by one of my other colleagues here, this idea of policies that declare, fetal personhood is embedded into these different policies. And framing these policies in this way allows folks to be charged for behaviors that might be otherwise considered legal behaviors, right? So like prescribed medication or experiencing pregnancy loss or, things that are not necessarily illegal, but framing policies in this way opens up this gateway for folks to be heavily criminalized. And it creates barriers to people exercising bodily autonomy and just complicates many areas of their life, right? And it just prohibits people from getting the type of care that they desire and deserve. I want to say that mass arrest and surveillance is something that we also see in Alabama. Um, Between 2006 and 2022, Alabama accounted for nearly half of all pregnancy-related prosecutions nationwide. And so this includes things like miscarriage, stillbirth, not seeking prenatal care, as I mentioned before, and just looking at our community as a whole. This kind of criminalization really shapes how Black and Brown folks engage with services across the board, and usually it is done under some kind of a threat. So the stress of that community-wide just creates other health concerns and other challenges for folks in community to navigate.
Absolutely. Thank you so much for raising that. I think, yes, like as we talk about our research, like these are individuals, but an arrest and prosecution has reverberations beyond the individual. And it's important to raise that when we think about the impacts and the harms of pregnancy criminalization. So again, we know that pregnancy criminalization is unfortunately happening in the context of maternal and infant health crisis across this country. And I wanted to pose to the three of you, how do we keep mothers and babies healthy? Dr. King, can I start with you?
Yeah. So just to put a little context on the maternal health crisis, the United States is 2 to 3 times higher. Our maternal mortality is 2 to 3 times higher than all other high income countries. And drug overdose is one of the leading causes of pregnancy related deaths. And while this number kind of varies depending on where you're getting your information, it's estimated that somewhere between 85 and 100% of these deaths are preventable, and they're preventable with better identification, better treatment, and better wraparound services. So when we think about those numbers, it's clear that the way that we're approaching maternal care, and particularly maternal mental health care, is not working at all. And so to improve maternal and health outcomes, I really think that one of the things that we need to do in healthcare and in policy and just in society at large is shift the focus to treating the mother-infant dyad rather than viewing them as separate patients. So didactic care is recognizing that mom and baby's biological, psychological, and social well-being, so all three aspects, are interdependent and interconnected, and it's emphasizing that care and support for one directly impacts the other. So examples of this are mothers are more likely to enter and remain in treatment when they can stay with their infants, so mom and baby programs, and keeping the dyad together in the early postpartum, whether it's in the delivery room or right after, so that they can do skin to skin or kangaroo care, really supports secure attachment formation and impacts long-term childhood development and maternal mental health. So when we shift this kind of focus, then we can start thinking when mom is healthy, baby is healthy, and create programs and policies that support the health of both.
I think Dr. Bowers signed off temporarily, but Caitlin, could you talk a little bit about the work your matriarch is doing to address this and improve?
Yeah, absolutely. I think that something that we consistently ran across that was working is when we see collaboration between our behavioral health entities, and especially those with specialized programming for pregnant parenting women, keeping them together, housing them together, state agencies, especially Child Protective Services, and then diversion programs, drug courts, and prosecutors. So if we have all of those people meeting together and understanding each other's work, that's where we see less criminalization, because there are more cost-effective and more long-term, for the family, better solutions. Not even just family, as Dr. Bowers was talking about, community. If we support each other, not only is it it's just more effective. So I think something that we've been really trying to do is finding the right language and approach in this hyper polarized media and political environment. It's harder to find common ground, or folks make it seem like it is, but it's still there. I mean, we all want safe, healthy moms and babies. We all want to keep families together whenever we can. And so I think something that we've really been trying to do is pulling up more chairs to that table, encouraging collaboration, advocating for those kind of relationships to be built, and trying to find that common ground again and the language in which that common ground can be navigated.
Thank you. Dr. Bowers, could you uplift some of the fantastic work that Yellowhammer Fund is doing to address this?
Yes, absolutely. So one of the things that we are super proud of is, again, the opportunity to invest in community programs. And as I mentioned earlier on, we have the Alabama First Equity Initiative, which is an initiative that is designed to organize community boards as well as to organize folks in community and motivate folks in community to participate in the process of building out birth projects, midwifery programs, and really working together to provide care and resources in places where we may lack access to care, with culturally competent providers, and making sure that folks are getting the services and care that they need. In addition, we will continue to do our mutual aid work, where we will take our medical access unit out into all across the state of Alabama to provide mutual aid resources to folks in community. And that looks like diapers and wipes and high chairs and playpens and things like that that folks need, just day-to-day materials that they need to support and take care of their families. I would also say that on the policy side, we continue to work to change policies that prosecute folks who use substances, and we'll continue to try to decriminalize pregnancy and pregnancy outcomes through our work in community on the ground. And I would say lastly, similar to Caitlin, looking at research and data as a way to kind of demystify some of the information that gets shared in community, so that folks in community actually can find that information usable, actionable, and that they're able, again, to find the place where they can plug in to be a part of finding solutions that work for folks in community.
Absolutely. Yeah, I just to quickly kind of respond, I think, Dr. King, when you shared that stat that 80 to 100% of these deaths are preventable, it's always staggering, just because the idea that we have the tools to prevent these deaths it's just a reminder that, like, we can that those better health outcomes, the idea that that when someone goes to the hospital and gives birth, they don't have to worry if this is going to be the last time that they leave the hospital. It means that they can actually go back and return to their community, their family, and enter into parenthood. And again, Caitlin, also just like uplifting Matriarch's work, and the way that you all have moved through Oklahoma to really to educate folks and have conversations across different areas of, like, the work, and to really, like, bring people in and say, hey, like, we have a shared goal, like, to keep mothers and babies together, to keep families together, and this is why this approach is wrong. And then again, Dr. Bowers, Yellowhammer's, I love the medical access unit. I think is such a wonderful way of bringing it to the people and going into communities and saying, if you're looking for diapers, if you're looking for playpens, if you're looking for food, like here, let me here, like we'll come to you. And that type of fostering that type of community and that type of yeah, just like love and respect is what gets people coming back. And in that moment when they are struggling and they say, hey, like, you know, I need help, we can be there to help them. And it's help that comes without shame or ties or you know, or extra baggage. And I think it's again, like it's just a wonderful way to live out your values. So yeah, so now I think we're going to transition into Q&A. I think we have some questions in the chat. Yeah, and Michelle, I want to bring you back as well in case there are other questions about the research. I think one of the questions we have actually that we can, as people think, is like, how should people support work in your state? Like, what can we do as participants kind of here? What can we do to support your organization's work?
Is that to a specific person, or do we?
I think
can we just? Okay.
Yeah, if Dr. Bowers, if you have an answer, go ahead.
Sure. So naturally, you can always provide your financial support to our organization. I didn't mention this in the earlier question, but one of the other things that we provide to community members in the Alabama area is universal basic income, which allows us to be able to provide a stipend to families who are in transition or who have specific needs that require monetary support. Obviously, we provide resources to abortion seekers who are going out to is welcome. We also have other opportunities for folks to donate period products. Any of our materials that as well. And if you are in the state of Alabama, we also always love to have volunteers to assist us with the various things that we do throughout the year. And so there's just a few ways that you can support our work. Please share, like, follow. We're on all social media. And if you have a question, reach out. We're there to answer you.
Thank you. Caitlin or Dr. King, do you have a response to that question?
I do. I think the first thing that came to mind is donating to your community-based organizations. They are the ones that are doing a lot of the boots on the ground work, which I think is some of the hardest in a lot of ways. I think be an informed voter. So get to like, you know, not only this, you know, whenever it's time to go vote, knowing the positions of the different people that you'll be choosing between, but like getting to know your lawmakers, the ones that represent you both locally at the state level and at the federal level. Share what you're passionate about with them and the knowledge that you have, so they can consider you a resource maybe when a bill comes up around perinatal, maternal infant health. And make sure that they know that you're passionate about this and that you have opinions and thoughts about how this policy needs to change. And then I think the last thing, and it's something we see a lot of in Oklahoma, I think it underpins a lot of these problems we've been talking about today, dispelling stigma. I think that's what underpins a lot of these more punitive approaches and why folks think that this is the direction that we need to take. Having conversations with people, finding that common language, and I think especially having conversations with people who think differently than you, and doing so in a way that doesn't make them feel shameful or defensive. It's very difficult to do, but I think especially for those of us that work in really more conservative states, that's a skill that sometimes gets lost, or can feel really hopeless. But if you can maintain that toolkit, maintain that language, and keep trying, I think that's how we're going to in the long run, drive change in this area.
And I'll just echo what Caitlin said. I agree 100% with understanding what resources are in your community and supporting those community organizations. A lot of them are grant funded and highly affected by changes in funding availability, but they are, like she said, boots on the ground, really doing deeply important work and meeting people where they're at. That includes the community health workers, the doulas, the peer support specialists, organizations like that. And then in being an advocate and sharing information, when we have these conversations with people who have differing opinions, just recognizing that things are not always black and white. There are there's nuance in the arguments, and so to just stay curious and actively listen. Like those are the things that I think are deeply important when we're providing education and we're hearing out others.
Thank you. So we have a question. I'm going to direct this to you, Michelle. It reads, in the cases where info was obtained in a medical setting to criminalize folks, did the research indicate that this info came directly from the patient charts or from provider reports? Is there more info on the types of providers, RN, OB, pediatricians, etc.?
Yeah, thanks for that question. So when we put our data together on information obtained or disclosed in a medical setting, that was again looking at charging documents and case files that police and prosecutors, that we see what they're alleging in these cases. We can see a bunch of different things. So we can see that folks were drug tested in a medical setting. That's part of that data point. We can see references to conversations between police and medical staff, disclosures by medical staff to police regarding treatment or other information in the medical file. We've been sharing a case narrative of somebody who, went to labor and delivery, and as soon as she learned that, as soon as the hospital learned she had not received prenatal care, providers conducted a urinalysis citing hospital policy. And when the urinalysis came back positive for methamphetamines, they asked her about her history of drug use. They spoke about it, and then, labor and delivery called law enforcement, sharing information about drug history, lack of prenatal care, and the health details of her infant. And then the same day, the police arrived in her hospital room with a warrant authorizing them to obtain samples of her hair and blood for drug testing. And so what we are seeing so far in these cases is this sort of free flow of information about, someone's medical history. We don't know, you asked about patient charts. We don't know about that right now based on the data, but that's something that we want to look into more. And you also asked about the types of providers. That's a really great question. That's something we want to continue to look into in our research to come. I hope that was helpful.
Yes. And Dr. Bowers, there's a question I think you might be able to speak to. It's addressed to you. It says, can you speak to the reality that pregnancy criminalization is occurring in tandem with the criminalization of midwifery?
Yeah. Oh, sorry, I was speaking on mute.
Well, I'm gonna turn you back over to your doctor.
A lot
You
of
don't need to see me on a regular basis.
intersections around criminalization of
I
midwifery
would say don't
and,
do any lifting over 10 pounds.
criminalization around pregnancy,
So,
because one wave is that you see many people in community seeking doulas, midwives to meet their birth goals or how they want to give birth. But the issue with that is because we hear this narrative that has been created around midwifery, that folks who are providing those resources, need to have certain certifications, need to have certain education, need to meet all of these required standards in order to be, and I'm using air quotes, in order to be qualified to help with births. And so there's a whole conversation that we can have around criminalizing midwifery, but I'm just trying to be in a nutshell. And so when those two things are working together, it creates again that fear within community that folks who would like to have those services or would like to provide those services, there's a gap that's created there. And so I think it's super important for us as we're talking about the first equity of sort of dismantling some of that stigma and doing away with some of that narrative that has been created around midwifery, specifically around Black midwives in those spaces who are providing that care for patients. That those folks are qualified. Their services are just as safe as being in a hospital. And it's really up to the individual for how they want to shape their birth experience.
Absolutely. Before we move on, and before I pass the baton to my colleague Ashley, I just want to thank all of you for your thoughtful responses and for taking the time to participate in this panel. It means a great deal to us here at Pregnancy Justice now, and I will now pass it to our Senior Policy Counsel, Ashley Sawyer.
Good afternoon. First, thank you so much to everyone that attended this webinar. We really appreciate you learning about this data center update. I want to direct everyone's attention to some policy implications. We talked so much about the impact of this data on moms, pregnant people, and babies. And so there is a bill being heard in South Carolina tomorrow, October 1st at 9:30 a.m. And that has extremely important implications for birthing people, moms, and babies. And if you're interested in learning more about the bill, I'm dropping the link into the chat for anyone that would like to attend. And then I will also share a link to an outstanding advocacy organization in South Carolina, the Women's Rights and Empowerment Network. You can follow them to learn more about how you can get involved in supporting their efforts related to that bill, SB 323 in South Carolina. So just want to say thank you again for everyone joining us for this really important data center update. And I also want to let folks know that if you're interested in taking action to ensure the health and best outcomes for pregnant people, the bill in South Carolina is an excellent opportunity for you to learn more about the impact of punitive responses on pregnant people and the potential long-term consequences of harmful and harsh legislation that targets pregnant people. And with that, I want to, I think, close us up. I would encourage everyone to follow the organizations mentioned today. So Pregnancy Justice, Metriarch, the Yellowhammer Fund. You can find all of their handles here. There's also a QR code here for you to find the Pregnancy Justice newsletters. So you can go ahead to pregnancyjusticeus.org or scan this QR code to get involved, learn more about this work, and learn more about how you can join the advocacy and the fight for the health, rights, and justice of pregnant people. Thank you all again for joining us, and have a great afternoon.